All right, guys, sorry I'm late. Thanks for joining me. So today, we're going to continue our discussion on the cardiovascular system. Now, rather than talking about the branches coming off of the heart today, I want to talk more about the heart as a conduction system. So electrically, we have to know how the heart works and how it makes it autorhythmic. So how does this system make your muscles of the heart contract and do it automatically? Well, I'm going to talk about that today. And I'm also going to talk about some other things. So for starters, I'll talk about the heart sounds and what makes those heart sounds. And then we'll talk about how when blood travels through the atrium and ventricles and vice versa, the pressure changes that you will see in the chambers. So let's start with the heart sounds for step one. All right, so for step one, guys, before we move on to understanding how the electrical system works, we need to better understand the heart sounds. So the sounds that the heart makes is very important because it lets you know what's normal versus what's not normal. What should you be hearing for a person's heartbeat? So we know that the heart sound makes this sound. Lub dub, lub dub. So that's how we remember it, using the terms lub dub. And that helps us remember and differentiate between what muscles are contracting to continue this autorhythmicity of the heart. Now, so for the lub, it's going to be, if you guys remember the terms systole, systole over diastole, then you remember how we measure heart rate or blood pressure. So systole is systole, diastole, systole, diastole. Thank you, Dr. Gonzalvi. Dr. Gonzalvi gave you that one. Anyway, so systole is contraction of the heart, contraction of the ventricles. And diastole is relaxation of the ventricles and contraction of the atria. So for the first heart sound, we used to think that it was as the blood rushes through its channels, the sound we hear is that initial thrush of blood through the channel or its valve. But it's not. It's actually due to the blood hitting a closed valve. So if systole is the ventricles contracting, would it make sense that your AV, the atrioventricular valves, which are allowing blood to come down into the ventricles, would be closed? And the semilunar valves, which are what the ventricles are shooting the blood through, would be open. So the sound that you hear during lub, during the contraction of the ventricles, are actually the hitting of the blood off of these closed valves, because they do close due to some pectinate muscles or the chordae tendineae, which we're not going to get into in this video. For now, the first heart sound is due to the closing of the AV valves. So then that leads you to believe the second sound should be the closing of another valve. But what valve is going to be closing during the second heart sound? So lub, dub, as it's shooting it down through the ventricles, now these valves have to be closed. The semilunar valves are going to be closed now. So that's going to be the second heart sound due to the closure of the semilunar valves. So if that's normal, then what's the third and fourth heart sound? Well, these are going to be abnormal heart sounds, or sounds you may hear in a patient with something like chronic heart failure or other conditions. Although there are exceptions. Now for the third heart sound, this is a ventricular gallop, and this is actually normal in some children. So for now, I just want you to put ventricular gallop and normal in children. And then for the fourth one, you're going to put an atrial gallop, and then just put that. Don't think any further on that. So that's the heart sounds, guys. These are the four heart sounds that you have to be familiar with when we talk about the heart. Because, you know, lub dub is normal, but you see complications in some people who have like regurgitation issues with heart murmurs or some kind of stenosis seen in like heart failure and things like that. So that's the heart sounds. Now let's get a better understanding of how it's able to do this. How does the heart stay autorhythmic, and how does it contract via the electrical conduction system? Let's talk about it. For step number 2, we're going to be talking about the cardiac conduction system. So basically, we're going to start understanding the heart as an electrical unit. And before I can do that, I got to make sure you guys are understanding what makes cardiac muscle different. We know that there's 3 types of muscle: striated, smooth, and cardiac. So what's different between cardiac and let's say something like smooth or skeletal muscle? Its main difference is in its cells and its ability to have intercalated discs. So the heart has intercalated discs, and that's something you need to know about. And this, mixed with gap junctions, allows for action potentials and ions to easily cross the membrane, and for the heart to contract very easily without the need of much energy. And in fact, the reason the heart is very different is because it's one muscle that never fatigues. It never dies out. It keeps going until until it no longer does. And then the reason for this is because of something that you need to be familiar with. Why is the heart autorhythmic? It is the SA node, but why? It's due to the leaky sodium channels. That is why the heart has the ability to keep regenerating action potentials. So let's move forward. Now that you understand that, I want you guys to take a second and think about how these 5 things are about to take place in a muscle contraction of the heart. So you know there are actually 4 phases of a cardiac contraction of the heart, but I want you guys to go look in that when you are talking about action potentials. Right now, I'm just going to talk about the SA node and how it's autorhythmic because of the leaky sodium channels. And it fires at a rate at about 80 to 100 times per minute, or depolarizes. And then the AV node, this is a little bit slower, but once it goes SA to AV, it goes about 40 to 60 beats per minute. And then these two superimposed come together and make up our natural heartbeat or average of about 72 beats per minute. So that's how you get your average beat per minute. And then you have the bundle of His, a little collection in the intraventricular septum. Branching apart, you have your left and right bundle fibers, which then go into the ventricles and pierce through the Purkinje fibers. These Purkinje fibers are what cause the ventricles to contract or to depolarize. Now, some differences you're going to have to know if you get to this level is that you're going to have to know the difference between basically the SA node's firing rate, so depolarization, and conduction velocity rate. So we know that SA node's the fastest at depolarizing at 70 to 100 or 80 to 100 beats. And we should know that the Purkinje fibers are the slowest. I'm not sure what they fire at, but the reason I'm telling you this is because for conduction velocity, that's a different story. The Purkinje fibers are actually the fastest at conducting its action potential, or its ability to allow a contraction. So that's pretty much all you need to know for step 2. And that's 1, 2, 3, 4, 5 components of this electrical system. Now we're going to make a connection between this electrical system and an EKG wave. But for step number 3, we're going to be comparing 3 different things here. We talked about the conduction system of the heart, but now we need to relate it or see how it coincides with an EKG wave. Remember, the electrocardiogram is just a way of measuring the electrical activity of the heart in order to further tell whether a person is having a pathology or having a such thing as like a myocardial infarction or a heart attack. But before we get into clinical application, we have to just cover the basics. What is PQRST? What is this bump? What are these points? And what is this bump? Well, if you think back to maybe an episode of Grey's Anatomy, if you ever watched it, or you remember in the hospitals where they have the machines that are going beep, beep. Yeah, well, that's what this is essentially. It's just measuring the electrical output of the heart. So let's talk about these letters. What does P stand for? This is going to be atrial contraction. That's what this represents, because we know the order of the electrical outlet starts in the SA node. So if it starts up here, then probably what's going to contract first is the atrium. Then it goes down and depolarizes down here in the Purkinje fibers, and then the ventricles contract. But that's not till here. And let's get there. First, let's talk about the PR interval. What is the PR interval? Well, if P is the atria contracting, then this segment here must be allowing time for the ventricles to fill with blood, so that when it gets to this here, it can contract to let all the blood back out. So PR interval is when the ventricles are filling with blood, they're relaxing. And then the QRS complex is when the ventricles are actually depolarizing. And then they will begin to contract to allow the blood to go throughout the rest of the body. And that's represented in the QT interval. This is basically systole of the heart. Systole, remember, contraction of the ventricles. So the QT interval is going to be systole, representing ventricular contraction. And then after that, remember, it's not just one single EKG wave. There's going to be multiple waves. And they're usually measured with a grid behind them that is representing time, because time matters in between these electrical impulses. For example, let's say this Q wave was elongated or longer than the normal, which you would learn if you were a cardiologist or if you learned how to read ECG tables. So for example, if this Q wave was elongated, you might be able to tell, well, someone had an old MI based off of that elongation. Or for example, if the ST wave, which we haven't talked about yet, is elevated, most people think in their heads ST segment elevated or tall ST means STEMI, so an acute myocardial infarction. So we have that there, and the ST segment, if you see the T wave here, you might be thinking, what's that wave? Well, this wave represents ventricular repolarization. So if you're not familiar with polarization, re versus depolarization, then I recommend you go and look at what an action potential is. In my head, when I see depolarization, I think becoming more positive, and when I see repolarization, I kind of think becoming more negative or relaxing. So if you're becoming more positive, you're probably contracting. So if that was contraction of the atria, then there must be relaxation somewhere in here, and it's hidden. So that's why you don't see it here, because it's hidden by the ventricular contraction. So that pretty much wraps up the connection between the heart and its contraction phases and its conduction system comparative to the EKG. So for the next step, I just want to do a quick recap of the heart as its blood pathways and how it works using pressure. So the pressure changes of the heart are pretty important for you to just kind of understand. So we will go over that.
This last and final step, I just wanted to cover the pressure changes that are seen in the chambers of the heart. And I just want to quickly go over this real quick. In the right atrium, it says that we have about 0 to 5 milligrams of mercury. In the right ventricle, we have 5 to 25. The pulmonary, 10 to 25. The left atrium, 5 to 10. The left ventricle, 10 to 120. And then in the aorta, 80 to 120. So it's funny that how the pressure started to suddenly increase as we got into the ventricles or the aorta. And if you were listening or paying attention throughout this video, I feel like this is when it starts to make sense because, for example, in the right atrium, why would we have about 0 to 5 milligrams of mercury? Well, the pressure in the atrium differs. And the reason is because 80% of blood flow is passively through the right atrium. So gravity helps bring blood down through the right atrium and through the tricuspid valve to flow better into the right ventricle. But it's not until it gets to the right ventricle that it starts to increase its pressure. And the reason that it increases its pressure in the ventricle is because then the last 20% of the atrium is due to atrial contraction. So the last 20% of the blood that shoots into the right ventricle is due to atrial contraction. And then now that right ventricle has to take that blood and send it to the lungs in order for it to get oxygenated. Now there's one thing that I wanted to mention real quick that I didn't, and it's due to these, there's waves, special pressure waves that you have to know about in the atrium. So if I talked about 3 vessels and we talked about a tricuspid valve, then would it make sense that we have 3 waves you have to know about in the atrium? And that's going to be the A wave coinciding with atrial contraction, the C wave coinciding with the pressure due to ventricular contraction, and then I believe we have something called the V wave. And I'm not going to have you remember or memorize what that is, but it's basically just the contraction or the pressure due to the force contraction of the pushing against the tricuspid valve. So anyway, let's move on. We have the pulmonary. So inside the pulmonary artery, the pressure is now 10 to 25. So as it returns, it starts to lower again as it returns to the left atrium because again, it's passively as it's coming back through the vein and it doesn't need as much pressure because it just has to transfer it down to the left ventricle. So once it passes the mitral valve into the left ventricle, now we see we have from 10 milligrams of mercury to 120. So the pressure differs greatly. And if you think about it, it's because mostly the muscular side of our heart is that left side. Because what does this blood have to do? This oxygenated blood has to travel up this aorta throughout the main 3 branches and down the descending throughout all the other branches just to supply the whole body with oxygenated blood. So it would make sense that this pressure would be pretty high. But it's not the highest. And I think the reason for that is basically as the blood pushes it through, it shoots up in the aorta, and because of the shape of the aorta and the bend that it has, it causes an increase in pressure in order to help push the blood through. I could be wrong on that, but that's just my understanding or my way of trying to understand, just in case a professor asks which valve or which chamber of the heart has the highest pressure. And it would technically be the aortic or the valve leading to the aorta. So, with that being said, that pretty much wraps this up, guys. So I hope it wasn't too hard to make sense of the heart as a conduction system, comparing it to an EKG, seeing how it relates, and then how all that coincides with the muscular contraction of the heart. So you pretty much got it figured out now, guys. Now it's just up to us to continue learning and keeping these things fresh in our head. So I hope to see you guys again. Thank you for watching this video, and stay tuned. Next week, I will be dropping another video on the descending aorta and the 3 main branches that come off of that. Thanks, guys. Health sucks. Let's talk about it.
Later.